Each one of you will have your own points to clarify. In any case, if you have any specific questions, we'll take it in the question hour and discuss these issues. I'm very happy to also the medical director of PORTEA, looking after all the medical operations and all the other medical related matters. I'm very, very happy to see all of you. And our next speaker will add a different perspective to our business, that is home care services. I want to introduce Dr. Somsekhar, a very dear friend of mine, as a surgical oncologist, and many of the things which Dr. Sukandi said, I'm sure he's made note of. He's very, very keen on documentation, even though he's so busy. I've seen his notes and summaries, so I don't think he'll get into trouble, madam. He's a very safe and good surgeon. Dr. Somsekhar did his MBBS from Mysore University, his MCH in surgical oncology from Gujarat, the GCRI, that's the Gujarat Cancer Research Institute in Ahmedabad. He's done his FRCS from Edinburgh. He's an expert in the robotic surgery area, and he has had fellowships in Buffalo, USA, as well as in Tampa in Florida and the USA. And today he teaches robotic surgery to many people. I remember I was faculty for one of his robotic workshops in gynec-oncology last year, or was it this year, Soms? It was a very successful program, and even though I'm not a surgeon, I sat through looking at all those wonderful pictures. And theoretically, he can sit here and operate in Manipal Hospital. That is robotic surgery for you. He's also a good gynec-oncologist, had training in gynec-oncology in the Mayo Clinic in the USA, in Rochester. And he has a lot of work in liver surgery areas also, where I'm associated with him. Colorectal cancer with liver metastasis, liver resection, when to do it, how to do it. And he's taken a lot of training in that area from Paris. His exceptional work, I think, is in the sentinel lymph node area. I don't know if most of you are aware, today we do not do an axillary surgery in early breast cancer without doing what is called a sentinel lymph node biopsy. And many a times, 30–40% of the time, or maybe more, the axillary surgery may be unnecessary, and the sentinel lymph node will say in whom you require a formal axillary dissection and whom you don't. And he is, I think, if I'm not mistaken, the highest series in India on sentinel lymph node biopsies. He's a DNB teacher. He conducts DNB sessions in Manipal Hospital for surgical oncology. He's an extremely able administrator. No wonder he is member of the Board of Studies at Manipal Hospital. He is member of the Business Advisory Board of MHEPL, that is Manipal Health Enterprises Private Limited. And most importantly, he does a lot of academic work in gynec-oncology, and presently he is the editor of the Indian Journal of Gynec-Oncology. He's been asking me to contribute. I didn't have time, not the material, I suppose. So anyway, Dr. Somsekhar for you and his perspective on home care. Soms, it's all yours.
Thank you very much. Uday is my friend, so sort of he overreads, and it really makes us shy. Okay, actually I think after a long time I'm giving a talk which has nothing to do with oncology. But probably nobody has used this service more than me who came it, because I'll tell you how it goes. When I was in US in Mayo Clinic and Pittsburgh and then in Roswell, I used to see the amount of documentation they do. I always see that we are at a very unfavorable thing. They want us to work for India with the patients, with the infrastructure, but they want us to maintain and practice what they practice in US. You can see that in US you'll never see more than 15 patients. In NHS, if you end up seeing more than 12 patients or 15, 20 patients, you cannot do legally. So here probably every hour we do that. and then and there everybody has to pay through their nose. So after you see 4 patients, I remember we used to operate 4 patients, go and sit in the lounge, 1 hour on your dictaphone, telling everything you want with a cup of tea, and they document everything, they show back. So here we end up like me, we end up doing 100 surgery a month, and I do about 100 a month. We see 70-80 patients a day. Patients from all quarters who come with 1 rupee to no rupee, and then we expect us in the court to do what we do. So I think if we really draw the line as we do Western, I worked in most of the hospitals in the world, then nobody in India can be treated at this affordable. Then government has to do something else. So, but having said that, in the court where you sit across the table is most important. So okay, so the person sitting on that has the luxury of always criticizing you. It's fine. Like in exam, they always say, when I took MS, they told that MS is not taken, MS is given. So don't think that you know knowledge, you will get it. We have to decide to give. It is the same way. So having worked in all these places, I really was amazed how those patients go home same day. Hours, number of days scheduled. The most successful loud surgeon was one who packs off the patient fast home. They don't have readmission rates, and then they utilize the OT maximum. I always remember in Buffalo University in Roswell Cancer Center, if a surgeon has certain % of readmission rate of their patient having discharge, they're censored. Readmission, that means, and how fast you send that bed vacant is, that's your increment and your score goes up, but without readmission. I used to wonder how they do that. I'll just show you. And I was amazed at the home care service they had, and I used to think why we don't have it. And the moment they came, I really grabbed it. I don't think anybody grabbed it more. We do a complex 100 surgery a month in my department, and nobody uses this more than that. It's a saying in my hospital, okay, surgical onco Dr. Somshikar patients, it's like a Bharat. They go home with the box, drains, everything, beautifully tubes. I say it's a gift to you. I train my patient before I take. I say all CA breast daycare. Morning you come, I tell them that there is a gift given from my hospital. There is a box. You go home, but our staff will come home to take care. Patient has this mental block. If you break this news pre-operatively, believe me, it's lovely actually. So my hospital loves me. They say that 48 hours is when all these beds are fed. Operate, 2 days later you can't trace that patient. They're in the home, and readmission rates are very minimal. I really embraced this whole thing with both hands, and I love this concept. The very reason we embraced it. So I will just take through what's my journey and little bit of data. I analyzed my patient last about 6-7 months. If you feel boring, please pardon me, because unless you plunge into this, you can't enjoy this. So that's only way is when you extend this to your patient and see what's happening to your practice, and then you will know. So what do we really mean home health care? This exactly the name is there. You remember we always say house and home. They say that I don't want a house, I want to make a home. So they always say that. So that term literally means that. When a patient walks into hospital, is an alien environment, alien sisters, all new people around you, uncomfortable, and then that block about doctors, white coats, tie or a suit, and then suddenly they are uncomfortable territory, add to that lot of anxiety, and they're supposed to repercutate it. I always asked all my patients when they come to OT, what is that which scared you? They told that when I lie down on the OT table, 6 lights and watching a dead roof is the worst thing I have. I always thought if I'm an hospital administrator, I'm going to put beautiful stars, moon, and a nice caricature of a painting. Believe me, every patient has told me, I always think that, okay, one night before you're sleeping or after surgery or the consent form or we terrorize stomach and come back, each and everybody has told that when you lie down, all the people, you can't watch anesthetic sister, but when you look the roof, please make the roof most pleasurable, because that's the last time many people may see if they don't come out of anesthesia, and then that pleasure is what they sleep, and when they get back after surgery, that's what is going to make. So how small things can matter. So you move the patient from an alien environment surrounding well-wisdom people and expect them to perform. So we know that if the whole environment can go back to their home, their backyard. So everybody, you may go to, you may stay in a 7-star hotel, 2 to 4 days, you would love to come back to your small house, where it is. So it's something like this. So really it's not a house care, it's a home care. So which means if there is a way we can move that here, it is not essentially one part. Doctors, the sister, medical practitioner, lab sampling, many things. I will just tell you, when I used to do total thyroidectomy for malignancies, I keep the patient for 3 days because I had to check their calcium, and I used to wonder just for calcium. But medically, I'm afraid. They go home, they develop a tetany, and something happens 6 hours, I just don't know. They have to come back to lab, and I can't trust a small roadside lab. Simple home care, I discharge all my patients same day, because next day I know 2-3 days, second, third, fourth day, calcium is done by her home care in the hospital. I get an email on my WhatsApp and I just know what's happening to the patient, and an MBBS doctor visits, I can move in off. So practically it changed. Excellent. So many malignancies has changed with me. So this is what I mean that we go. I'll just tell you one example. You know, we do a lot of surgeries and patients come every day, move down for a lymphopress exercise when you do a breast surgery, axillary clearance. Just moving that machine and putting the trained person, it's, mind you how much your poor patient they are, they're ready to pay any amount for these things. And I you know, one beautiful thing that all my patients say and they love is, when I have to see you, I have to take an appointment 4 months, I have to pay, doesn't matter. I sit between everybody and you will give 5 minutes. Home care, all the time for them. You know, it's like lovely. It's like the president walks into your home for actually a dinner rather than you walking there and watching them for 2 seconds. So you can just see that, you know, this is one of the examples from our hospital. 2 elderly people, very nice people. They gave all the education to the children, both children very educated in US. You know that every day it happens. So they stay 90 years, 80 years. Once we are 60 plus, we accumulate all the disease, hypertension, diabetes, blood sugar. So you have to walk down to every place. You need a doctor consult, a lot of medications, blood sugar monitoring. Imagine if the home care moves down there, what is going to happen? It didn't have to be diseases and surgery. That's what I mean to say. All of us are going to acquire chronic diseases which will keep us alive but make our life tough. So this is one of our patient where, you know, if you see that they're almost like 84 and 80, very rich people. Money doesn't matter. Health and wealth totally is different issue. So if a home care moves there, what it can actually make. Now people say always that home care is not for India, where no bread, butter and 2 rolls of dhoti, and then they can't even come for infectious disease, tuberculosis. This is all modern thing, you know, go to US, UK. Actually, if you take it, it's totally the other way around. It's really required first here, not there in the other place. The things, the system are very well placed in UK, US or anywhere you go, wherever I work. In India, doctor pool is one of the best. System is very poor. So doctor couples as the system plus a clinician and do that. So imagine if the system supports you, what fantastic work you can do. So all the more we need it. In India it is very expensive, slow and inaccessible, and I'll just show you. Very expensive. Seeing a doctor of 500 is the most economical thing. You call a plumber tomorrow, 1,000 rupees he'll not come. I'll be operating, my mom calls. Electricity, gone, call the electrician. He will never touch by 1,000 rupees. I will guarantee you, you have a gas geyser gone, he will charge going and coming. I look back, easiest money, most economical is a doctor fee in India. You call anybody in the home with who has done a 10 pass or 7 pass for a small work, he will not even come to your home. First, you can't find him. He will give a time. Then he will come and charge like hell. So remember, doctor fee is the least in India. So what is the act? Coming down to a hospital, in a traffic, paying to and fro, because you come, you eat somewhere there because it's a full day affair for you, and you cannot come alone, you take somebody, they lose the job. So the expensive part in India, beside medication docs, is what actually makes you travel,